Hi, today I'm going to be presenting a patient that came in on 2/24 of 21. Our patient is Dalali Wang. Like I said, she was admitted on 2/24/21. She is a 90-year-old female. And she came in for shortness of breath, cough, weakness, and chills. Her serum creatinine is 1.4 and her creatinine clearance is 20. She weighs 47.7 kgs and she is 61 inches tall. Her past medical history includes hypothyroidism for 20 years and ankylosing spondylitis for 10 years. She is a non-smoker, no alcohol use, and she does live in an assisted living community. Also no family history relevant. She is allergic to penicillin, which she does get a rash when she takes it. Medication that she was on prior to being admitted include aspirin 81 milligrams by mouth once daily, levothyroxine 0.088 micrograms by mouth once daily, calcium with vitamin D 200 milligrams per 20 micrograms by mouth once daily, folic acid 1 milligram by mouth once daily, and methotrexate 7.5 milligrams by mouth once weekly. Like I said, she came in for shortness of breath, cough, weakness, and chills, and her past medical history of present illness includes the patient was presented to the ER with wheezes bilaterally and rhonchi on the right, fever, chills, weakness, hypoxia, shortness of breath, and productive cough. Patient was admitted due to her age and due to the fact that she does use a biologic for ankylosing spondylitis. And until a week ago, she was fully independent, walked around with a walker, and went to meals in the dining room. Her problem list includes bacterial pneumonia, ankylosing spondylitis, and hypothyroidism. Going on to the progress and plans. The first one was severe bacterial pneumonia, and it was caused by Streptococcus pneumoniae, as evidenced by confusion, because she was not oriented to the date. Uremia, which was a BUN greater than 20, and hers was 35, and hypotension, which her blood pressure was 92/58 upon admission. This resulted in her needing fluid. The patient also has short of breath, a productive cough, weakness, chills, and a fever of 103. A chest X-ray was taken, and results did show lower right lobe pneumonia with basilar precardial consolidation in the right lung. Cultures were taken, and results suggested Streptococcus pneumoniae. The patient was started on 1 rad of albuterol, oxygen, and normal saline in the ER. The normal saline and oxygen via the nose canal should be continued when transferred to the inpatient setting. Anti-MRSA medication should not be started since we already did receive the culture results back. Ceftriaxone 2 grams IV Q24 hours and azithromycin 500 milligrams IV Q24 hours should be started as well. We should continue these until a negative blood culture is achieved, and then we continue to give those for an additional 14 days after that negative result. We should monitor for fever, cough, her blood pressure, her BUN, her orientation status, and a clear chest X-ray. We should also monitor her for fever, cough, blood pressure, BUN, headaches, stomach pain, NVD, flushing, allergic reaction, and IV site reaction and irritation. The patient should start to feel better after 42 hours, and upon discharge, we should switch her to oral medication. Going along with that, microbiology results, she did get a gram stain with moderate gram-positive cocci and plasmodium white blood cells in her septum culture. Blood cultures are pending. Like I did say, she did have a chest X-ray. She is alert and oriented ×2, but she's confused on the date. And a lab testing suggests a blood PCR for Streptococcus pneumoniae is positive. Moving on to her next problem, her controlled ankylosing spondylitis due to patient being on methotrexate, 7.5 milligrams once weekly, the calcium, the aspirin, and the folic acid. This is a controlled disease state, so medication should be continued during and after the hospital stay. We should monitor the CBC with the differential and platelets, serum creatinine, BUN, LFTs, fluid, and electrolyte status. Moving on to our third controlled problem, we have controlled hypothyroidism through the patient being on the levothyroxine once daily. The medication should be continued during and after the hospital stay as well. We should monitor the heart rate, BP, new or worsened cardiac symptoms, and signs of hypo and hyperthyroidism. And we do not have a thyroid panel on her yet, so we should get one of those in order to determine if this medication is necessary for her to continue to be on. Like I said, she was started on normal saline, albuterol, and oxygen when she came in. When she gets transferred to the floor, she should continue all her at-home medications, plus the oxygen and normal saline, since she is dehydrated and her O2 stat was low. Vitals: when she came into the ER, her blood pressure was 92/58, a temperature of 103, heart rate of 87, a respiratory rate of 22. Her O2 stat was 89, but then it did go up to 93 after oxygen was given. And she did have a score of 1 on a pain scale when taking a deep breath and or coughing. These were monitored then roughly about every hour, give or take a half hour, when she was admitted. So her blood pressure did come back up to 101/64, 102/68, and 108/70. Her temp has come down from 103 to 102 to 101, which is a good sign. Heart rate did go from 87 to 94 to 88, roughly then back to 90. Her respiratory rate did decrease from 22 to 18, and her O2 stat, like I said, did come up to 93 and 94% on oxygen. Other than that, she did receive a urine analysis, and the only thing to mention from that, it was dark. It was a dark yellow, and the clarity was slightly cloudy, and this was due to her being dehydrated. So once we do get her rehydrated with the fluids of normal saline, she should be back ready to go. Other than that, I have nothing else to report. So please let me know if you have any questions. Thank you, and have a great day.